Good evening, dear students and participants, and good evening, sir, respected Professor Nagaswamy, sir. Today we will be having a clinical case discussion. The case will be presented by Dr. Rajesh Kumar from RH Perambur, third year DNB student. Over to Dr. Rajesh. Dr. Rajesh.
Good evening, sir.
Good evening. Have you been given any case scenario or you are just presenting a hypothetical case?
Presenting a hypothetical case.
Okay, go ahead.
Vasanthi madam has joined us, sir. Good evening, madam.
Good evening, madam.
I think she's still not unmuted.
Shall I present the case, sir?
Yeah, go ahead.
So my case is a case of pregnancy-induced hypertension, sir.
Okay.
Gayatri, a 27-year female, coming from Ayanavaram, Chennai. Husband is working in ICF Railways, sir.
Okay.
Presenting complaints, missed period for a period of 8 months, and swelling of lower limb for 2 weeks. History of presenting illness. She is a primary para, second gravida. Her last menstrual period is on 17th of April 21, and her expected delivery date is on 23rd of March 2022. Her gestational period is 34 weeks and 3 days, sir. Antenatal history. First trimester, she got registered at an antenatal clinic in a private hospital. She was started on iron and folic acid tablets. She had no history of severe vomiting or any other significant illness during her first trimester. Second trimester, quickening is felt at 5th month. Tetanus toxoid dose has been administered. Her first visit was at Railway Hospital at 21 weeks of gestation. While presenting, she had a BP of 150/96 mmHg. She was started on nifedipine 20 mg BD. She got discharged after 1 week of monitoring, and she has been advised blood pressure monitoring, fetal movement monitoring. No further visits were in the second trimester. Third trimester, she visited to antenatal clinic at 34 weeks of gestation. Now her BP was 174/100 millimeter of mercury, and urine albumin dipstick test was 1+. She had fetal movements presentation. No history of headache, visual disturbances, epigastric pain, jaundice, or decreased urine output or seizures. No history of bleeding per vaginum. She got admitted in ward. Her BP was monitored regularly, and she was started and her antihypertensive medication continued with adding up of labetalol 100 mg BD. And her urine albumin has been monitored 4th hourly, and injection betamethasone 12 mg IM OD for 2 days has been given, sir. Past history, she has no history of any previous illness or chronic hospital admission, no history of any previous surgeries, no significant family history, no known any drug allergies. Past obstetric history, she got married 4 years ago. Her previous pregnancy was uncomplicated, full-term normal vaginal delivery. Her baby is healthy, and birth weight was 2.8 kg, and the baby cried immediately after the birth. No history of any NICU, neonatal intensive care unit admission or any fetal anomalies. Menstrual history. Her previous menstrual cycles were regular, of normal flow, no clots, 3 to 5 for every 30 days. Personal history, no addiction, normal bowel and bladder habits. She is an housewife by occupation. General examination, her weight is 65 kg.
One second. Before you go for your examination, I don't know whether I heard you wrong or whether you mentioned like that. You said she's a primary gravida, isn't it?
Primary para, second gravida.
Primary para, okay. Primary para, second gravida.
Yes, sir.
Yeah, so do you call a second pregnancy as primary para? Parity 1, live 1, like that? You have to say gravida 2, live 1, and now this is the second conception, isn't it?
Yes, sir.
Okay. Then what about family history? During first pregnancy has been almost normal. But second pregnancy, she has gone in for almost similar to a hypertensive crisis.
Yes, sir.
So what about what are the etiological factors you have to trace from the history?
Sir, there was no significant family history of hypertension or any coronary artery disease prevailing in her
Any
family.
mother or sibling had a preeclampsia or a hypertensive disorder of the pregnancy?
No, sir. No, sir.
That history is very important, isn't it? You should ask about that also. Okay, go ahead.
Even if, I think even if that's negative, having said that, I think he has to mention that it is not there, no, sir?
Yeah, that's what I'm saying. Even a negative history, family history, you should know sibling or mother had a similar problem. That also has to be mentioned. Okay. Right. Go ahead.
Going with general examination, sir. Her weight is 65 kg. Before pregnancy, her weight was 56 kg, sir. Her height is 150 centimeter. Her BMI is 28.9 kg per meter square, sir. She is afebrile, not pallor, not icteric, no cyanosis, no clumping, or no lymphadenopathies. She has bilateral pitting pedal edema of grade 2 plus. Sir. Neck veins not engaged. Pulse, her pulse is 110 per minute, regular, normal in volume. All peripheral pulses were felt, sir. Her blood pressure is 176 over 100 millimeter of mercury in right upper arm in supine position. No signs of any bleeding manifestation. She had been given labetalol 100 mg stat dose, sir. After that, her BP was 133/87 of mercury. Systemic examination, respiratory system. A respiratory rate is 22 per minute. Bilateral air entry is present. Normal vesicular breath sounds here. Cardiovascular system, her heart rate is regular. S1 and S2 heard, no murmur. Apex beat felt at the fourth intercostal space, 1 centimeter lateral to the mid-clavicular line. Abdominal system, on inspection, her abdomen is distended. Umbilicus is inverted. Stria gravidarum present. Palpation, her fundal height is 32 weeks. Vertex presentation, no epigastric tenderness. Auscultation, fetal heart rate heard at 160 per minute. Central nervous system, she is conscious, oriented to time, place, and person. Her motor function, tone, and deep tenor reflexes were normal. Sensory function is intact. Fundus examination not done, sir.
Not done.
Airway examination, mouth opening allows 3 fingers. There is no loose teeth or dentures. Thyromental distance is more than 7 centimeter. Sternomental distance is more than 13 centimeter. Neck extension and flexion is adequate. Thyromandibular joint is mobile. Mallampati grading is grade 2, sir. Provisional diagnosis. A 27-year second gravida at
What about
34
the
weeks.
back and spine? Do you examine the back and spine?
Yes, sir.
You should mention that, isn't it? After completion of airway, it is always mandatory that you mention about the back and spine also.
Yes, sir.
Whether there is any edema or all the bony landmarks are felt easily. Isn't it?
Yes, sir.
Don't forget that. Okay.
Back and spine normal, sir. No edema present, sir. No scoliosis or any deformities present. Provisional diagnosis, sir. A 27-year-old second gravida at 34 weeks of gestation with severe preeclampsia planned for elective cesarean section.
What is the indication for cesarean in this case? Why could not they allow a normal vaginal delivery? She has had one normal vaginal delivery earlier.
Yes, sir.
Why
But
they have decided to?
Sir, BP initially after labetalol it came to 133/87, sir.
Okay, so
But
that is
later
getting under
monitoring
control.
But later on monitoring her BP did.
Now, what is her gestational period time?
34 weeks and 3 days.
34 weeks and 3 days. So the baby is mature enough. Has they done an ultrasound to assess the growth of the child? Will it be viable if you take it out now? What is the ideal time to deliver a baby? But all you
That
want
is
to do it before the full term completion,
37, sir.
36 weeks. Okay. Why you have to wait till 36 weeks?
So for the
Ideally-
fetal lung maturity, sir.
Fetal lung maturity. Very good. So they have some lung issues if they deliver earlier than that. Okay.
Yes, sir.
Now that she's responding well to labetalol, what is the hurry in going in for cesarean section?
But her later BP didn't come below 160 per 100.
Did she have any features of hypertensive crisis? Is it just by the reading do you go, or you go along with other clinical features of high BP?
So
What
no other
are the imminent threat to the life of the mother if the BP is not controlled well?
other signs of imminent dangers.
Does she have any severe headache?
No,
Any
sir. No headache, no visual disturbances.
nausea, vomiting? Nothing is there, isn't
Nothing
it?
is there, sir. Yes, sir.
Then when she is asymptomatic and only the BP is high, is there a absolute indication to go ahead and do a cesarean at this stage? Or can she be monitored after admission in the hospital and watched for any newer developments? Is there any particular investigation available to find out which system you are worried about if the BP is constantly high?
Sir, central nervous system.
Central nervous system. Very good. So, is there any investigation available to find out whether the central nervous system will go in for any complication or not if the BP is not coming under control?
So there's a ultrasound. They are not done, sir, but we can find it out with an ultrasound. With
Ultrasound of what?
eye, sir. Yes, can ultrasound of eye, we can find the optic nerve sheath diameter.
Diameter.
If the
Very
nerve
good.
sheath diameter is found to be more than 5.8 mm, then it resembles of intracranial pressure of more than 20 millimeter of mercury, sir.
Very good. So that is one mode of investigation. Any other mode you know? Any other investigation available?
Any clinical and biophysical profiles are there, sir. Rollover test can be performed to find out.
Rollover test is it for eclampsia? I mean the central nervous system problem?
Not for central nervous system.
My question is one test you said is ultrasound of the optic nerve sheath diameter measurement. I completely agree with that. That's one of the important newer modes of usage of ultrasound in the pregnant women for finding out any imminent threat to the central nervous system.
Yes, sir.
Similar to that, is there any other investigation available to find out the central nervous system complication? That is the question. Are you aware of any other test?
Transcranial Doppler can be done, sir. Middle cerebral artery velocity Doppler.
So have you heard of RC? Regional cerebral oxygen saturation, RCSO2.
Yes, sir. Cerebral oxygenation monitor. Cerebral
Monitor.
oxymetry, sir.
Yes, that is supposed to be more specific, okay, rather than your transcranial Doppler, which will give you only about a global perfusion, whereas a regional cerebral hemoglobin oximeter saturation, hemoglobin oxygen saturation is supposed to be as equally important as your optic nerve diameter measurement. So these are the two. Any other usage of ultrasound in the pregnant women, especially in pre-eclamptic women?
We can
Other
count
than
out
these two examinations which you can utilize it for, any other
examination of other
indications?
systems. Examination of other systems can be performed, sir.
Like what?
For a cardiovascular system, we can find out the diastolic dysfunction, systolic dysfunction if it's there, and we can find the left ventricular end diastolic pressure, sir.
Okay, that's normally we do. That's a echocardiographic examination that we do. Anything else?
Abdomen. Abdomen. You can do something in the abdomen.
For finding out the hypovolemia and vasoconstrictive state, you can do IVC diameter, sir.
IVC diameter, is it very easy to find out in a pregnancy, especially in the advanced stages of pregnancy? Lung fluid measurements,
Lung
okay?
fluid.
Gastric volume measurement, and you can do airway assessment.
Yes.
And you can use it for vascular access in cases of anasarca or severe edema due to preeclampsia. Can use it for vascular access, and you can use
Spinal
it
and
for
epilepsy.
neuraxial blockade. So there are 6 indications for usage of ultrasound in preeclampsia. One is for
And liver, sir. Liver, sir.
liver. Yeah, if it is HELP syndrome, you can go for liver examination also. Okay, so by using the optic nerve sheath diameter or the regional cerebral oxygen saturation, we can wait and allow because we will be more happy if the baby grows little more and attains
Yes.
more lung maturity before we urgently deliver this baby. Okay, right. Anyway, Ojishin has taken the decision. She wants to do an elective cesarean section, not an
Yes, sir.
emergency one. Okay, right. So how will you proceed to give anesthesia for this patient now?
Sir, after routine pre-op evaluation, sir.
What
and
are the
examination,
routine? What are the routine pre-op evaluation you would like to do in this case?
sir, history pertaining to the history and obstetric history, airway history, significant family history after completing the history, general history about the patient, sir. And then after airway examination, specific airway and spine examination, I will go into the investigation, sir. Investigations, I'll ask for complete blood count to look for hemoglobin, hematocrit, total count, and platelet count, sir. And I'll ask for
What changes can you expect in this? Will this being be normal, or do you expect any alteration in this in blood count?
I expect for an thrombocytopenia, sir. Reduction in platelet count because of preeclampsia induced platelet activation and aggregation. With microangiopathic hemolysis, I suspect anemia and thrombocytopenia, sir.
Thrombocytopenia. Okay. Now that you have mentioned about platelet activation, what is the pathophysiology of preeclampsia?
Sir, vasospasm. Main pathophysiology is vasospasm, sir. Because of the failure of the trophoblastic invasion into the maternal spiral artery leads to failure of trophoblastic invasion leads to maladaptation of the maternal spiral arterioles. This leads to the improper villus development, leading to fetal hypoxia and fetal growth restrictions.
So do you normally describe it in stages or just like that by straight away vasospasm? Is it in the books? How is it described? Is it described in 2 stages, stage 1 and stage 2, or straight away as a vasospasm and failure of trophoblastic invasion? Is it like that? What is stage 1 and stage 2 in the pathophysiology of preeclampsia? And how it is classified based on the time duration of gestation? It is called preclinical and clinical based on the time of gestation. Okay, and stage 1 is the stage where the implantation of the placenta into the maternal decidua should take place. Okay, so that is the failure happening at that stage, in failure of invasion of trophoblast to convert the small caliber resistant spiral arteries into large caliber capacitance vessels. That fails to happen in the first stage, which takes up to 20 weeks. Okay, that's why it's called preclinical stage.
Yes.
Once this failure has been completed, that not properly invaginating and then trying to convert this spiral arteries into capacitance vessels, this leads to ischemia, and that causes endothelial activation is the second stage. And the endothelial activation, what does it result in? There are 2 imbalances taking place. What are they?
Sir, reduction in, reduction in prostacyclin I2 and increase the thromboxane A2 synthesis, sir.
So imbalance between vasoconstrictor and vasodilator
Vasodilator.
happens, number one. What is the other imbalance?
Sir, nitric oxide reduction.
No, nitric oxide is also a vasodilator. That is what I have said already. Vasodilator versus vasoconstrictor imbalance. What other imbalance also happens?
Sir, inflammatory
And anti-angiogenic factors. Pro versus anti-angiogenic. That is, new angiogenesis should take place when there is a placental growth happening. New vessels should form. This vessels formation is also impeded. So there are two imbalances taking place in stage 2. Right? This only leads to 3 types of changes because of this endothelial damage or activation. What are the 3 changes that happen? One is called vasospasm, as you said. The second is capillary leakage. Third is activation of coagulation to form microthrombi. Okay? So during the second stage, the 3 changes that happen following the activation of endothelium or endothelial damage is vasospasm, capillary leakage, and activation of coagulation. Only the 3 take place. Is there a marker nowadays to find out the severity of these changes?
Yes, sir.
Oh.
Maternal placental activating plasma protein A, sir. And then platelet growth factors.
Platelet growth factor.
Pregnancy associated plasma protein and then
Any soluble fragments?
plasma fibrinogen.
Plasma fibrinogen is not there. Okay. Right. So this is the pathophysiology that happens in these patients. And now you want to see whether there is any alteration in the platelet. So what is the minimum platelet you will accept for this patient?
Sir,
That if at all there is such alteration or change in the platelet count, what is the minimum you require to administer any type of anesthesia, whether it's regional or GA for this patient?
according to the NICE guidelines, if the platelet count is more than 80,000, they can be treated as a regular parchment and neuroaxial anesthesia can be administered, sir.
Supposing she has bleeding and 80,000, will you accept her? She says whenever she brushes, she has a bleeding, but her 80,000 is there. Will you accept? Then it should always be correlated with the clinical scenario. Patient may be having 1 lakh or 1 lakh 25, but still there may be some petechial hemorrhages taking, bleeding when the brushing. Okay, if that is there, it is not a good sign. Yes, on the contrary, you have only 80,000, absolutely no bleeding anywhere, patient is happy, then you can safely take up that patient. Okay, so the number is not alone sufficient. You must ask about the bleeding tendency in the patient also. Okay, right. Then what other investigations you would like to do?
As for a random blood sugar, sir.
Okay.
And renal function test to look for serum, urea and serum creatinine, sir. To find out any.
Supposing the patient also had proteinuria, what are all the various grades of urine proteinuria you can expect?
So, based on the urine dipstick test, 0, 1 plus and 2 plus.
0, 1 plus, 2 plus.
So up to 1 plus, 0 is less than 100 mg per 24 hours, sir. Urine protein excretion is less than 100 mg for 24 hours. If the urine 1 plus grade is if the urine protein excretion is more than 500 mg per 24 hours, it is 1 plus, sir. 2 plus is urine protein excretion more than 2 gram per 24 hours is 2 plus.
I thought it's 1 and 3. 1 plus is 1 gram and 2 plus is 3 grams per liter of you. Okay, right. So, what is the importance of this albumin urea in the urine? In what way it is clinically relevant? The higher the, supposing she loses a lot of protein in the urine.
Sir, our plasma oncotic pressure will get reduced, sir.
Mm.
In spite of pregnancy being an increased hydrostatic pressure, there is more chances of capillary leakage and vascular permeability, sir, leading to extravasation of fluid and pulmonary edema.
Can you correct this by giving albumin to the patient?
If she is found to be severe hypoalbuminemia, serum albumin level is less than 3 gram per deciliter, then we can correct.
What is the danger of giving any colloid to a patient with preeclampsia?
Sir, already preeclampsia patient will have chances of throwing seizures, sir. And because rise the ICP, their colloid administration is usually avoided, sir.
So is it because of the seizure activity or some other reason? Which book says that it will cause seizure? Do you have the reference for that?
Usually albumin is avoided in traumatic brain injuries.
We are not dealing with traumatic brain injury here. We are dealing with pregnancy. So in what way colloids are to be very carefully given in preeclamptic patients?
Nephrotoxicity is also been due to colloids administration.
They can easily go for overload because they have a contracted pulmonary edema is very common and it's very difficult to eliminate it by giving diuretic. Okay. Crystalloids you can easily remove from the body by giving a diuretic therapy, whereas colloids you cannot remove that easily. Okay, so you have to be very, very careful when you administer a colloid for a preeclamptic woman. Unless you have proper cardiac monitoring, it is very risky to just like that administer a colloid for a preeclamptic woman. You must remember that. Okay, right. Okay.
So one question, sir.
Yeah. Please ask.
What happens to the intravascular fluid volume? It is very much same as what sir was asking. What happens to the intravascular fluid volume in patients with PIH? What is the percentage of reduction in the intravascular fluid volume in severe PIH? That's why he said, no, intravascular fluid volume is reduced. In spite of the edema, it is intravascular fluid volume is reduced, and any amount of little bit of colloids and other things that you give can precipitate pulmonary edema. So what happens actually? So that's why we should not give him diuretics also, because the intravascular volume is already reduced. And colloids can produce a problem. So how much, do you know how much percentage? It's about 30%. Yeah, it's about more than 30% of the intravascular fluid volume is reduced, especially in patients with severe PIH. And though the total body water is increased.
Okay.
Yeah.
So urine, why the urine albumin leakage happens? What is the mechanism? We normally talk about proteinuria, isn't it?
Yes, sir.
Now the features. Is
The
proteinuria
latest
made a compulsory now, the newer concept in preeclampsia? Is it proteinuria a compulsory component to be branding a patient as preeclamptic? Initially they said the triad, hypertension, proteinuria, edema. They removed
edema is not taken off, sir.
edema was taken off long back. Now, do they accept proteinuria as a must criteria to say a patient is preeclamptic, or now that also has been removed? The latest current concept guidelines. They say proteinuria also is not mandatory. Okay, the latest
Rajesh,
guidelines concept say that instead of that, you look for features of any involvement in the central nervous system, like visual disturbance, headache, nausea, vomiting, or stroke, or features of mild cerebral hemorrhage, or liver involvement like epigastric pains, stretching of the capsule, or urinary involvement like severe proteinuria, reduced renal output, urine output. All these things are now taken into consideration. So based on this, now how do they classify preeclampsia? Previously, preeclampsia was classified based on the BP as mild, moderate, and severe. Now, how do they classify that?
Sure. Complicated and uncomplicated preeclampsia.
Preeclampsia with severe complications, preeclampsia with no complications. Okay, that is how they classify. So that is why now they have removed the proteinuria also as a compulsory component in the, to brand a patient as preeclampsia, right? Right. So what is the mechanism of the renal involvement here?
Sure.
Why normally a healthy kidney does not allow protein or albumin to come in the urine?
Because the glomerular basement membrane reflects the negatively charged ions.
One reason.
Since albumin,
What is the how does it have a negative charge? What is the protein that is there to create that negative charge? So like poles repel, like charges repel. There's something called heparan sulfate. Okay, so that heparan sulfate is damaged because of the damage to the endothelium as well as the basement membrane. That negatively charged heparan sulfate and chondroitin, these two negatively charged particles are not there. So albumin, which is also negative, which is normally repelled, is allowed to pass through. Okay, that is the mechanism of this renal damage. Okay. Right. What is the basic minimal volume of urine a preeclamptic patient should void to indicate that the renal function is still normal? Minimal per hour of urine output, which you will consider as healthy and okay, acceptable. What is the normal urine output in a healthy, otherwise a normal patient?
More than 1 ml per kg per hour.
0.5 to 1 ml per kg per hour we accept. Okay. So what is the minimal that you will accept as a normal in a preeclamptic patient?
More than 0.3.
It is not based on body weight. It is a flat number. Minimum 25 ml per hour. Okay, 100 ml for 4 hours. Even if there is no output in 1 hour, they say at least for 4 hours you should have 100 ml of urine output. And this knowledge, why it is important for you? Supposing she has a tendency to throw a fit, or she has progressively increasing BP with severe headache, and the physician is scared that she may throw a fit anytime. What drug she would like to start?
Like MAC, because of the magnesium sulfate administration.
So whenever
it already decreases urine output.
So before you start magnesium, you should see the urine output chart and see whether there has been at least 100 ml for the last 4 hours. Then only the magnesium should be started. Otherwise,
Why should you check? Why should you check?
Magnesium is mainly eliminated via kidney, madam.
Very good.
And then magnesium toxicity, urine output is also reduced severely.
So what is the normal magnesium level in the blood?
1.2 to 2 milliequivalents per liter.
Milliequivalents per liter. What is the minimal therapeutic level required to act as an anticonvulsant?
5 to 8 milliequivalents per liter.
Milliequivalent. At what level cardiac arrest will occur?
More than 12 milliequivalents per liter cardiovascular.
More than
12 milliequivalents per
12 milliequivalents. That's very small dose. So if I use it 5 to 8, only 12, there is such a short therapeutic range. When will the patellar reflex get obtended?
More than 8 milliequivalents per liter.
10 milliequivalents. Even that will take 10. Then respiratory, then cardiac conduction defect, then finally cardiac arrest will occur at 25 milliequivalents. Okay. So that much of large gap is there. Right. What are the mechanisms by which magnesium sulfate is helpful in preventing an eclamptic seizure, and what are the other actions it produces?
Magnesium sulfate mainly prevents the presynaptic acetylcholine release and prevents binding of acetylcholine at the post-junction receptors.
That is neuromuscular junction. Okay.
Antagonist of calcium, sir, thereby reduces calcium binding and activation, sir.
You are starting with the peripheral action, but we are more interested in the anti-epileptic or anti-seizure activity. Where does it take
NMD,
place?
yes, sir. It inhibit NMD.
So always start with the central nervous system effect. Okay. So antagonizes the NMDA receptor,
NMDA
which is a
effects, sir.
stimulant.
So,
Okay. Then.
glutamate and excited neurotransmitter is prevented from acting, sir.
Very good. What is the effect on the respiratory system?
It causes bronchodilation and in overdoses it causes respiratory depression, sir.
Overdoses, but therapeutic effect only I'm asking.
Bronchodilation, sir.
So can it be used in status asthmaticus?
Yes, sir.
What is the dose? What other anesthetic agent can be used in status asthmaticus?
Ketamine, sir.
Vitamin. Okay. Right. Right. So how do you treat magnesium toxicity?
Sir, call for help, sir.
Call for help.
Secure airway breathing circulation.
Okay.
Then IV calcium gluconate, sir. 10% of 1 gram calcium gluconate over 10 minutes.
Okay. Very good. So what are the various regimes that are followed for magnesium therapy? Any specific names are there?
Pitchard's regimen,
Pichard regimen,
Zuspan regimen,
Zuspan regimen,
Zubai regimen, sir.
Sibai's regimen. Very good. Okay. All the three are there. You know the details, how it is administered in Pichard and how it is administered in Zuspan and Sibai's. Okay.
Only
You have to
Pitchard
learn
regimen
all that.
I know.
One is both IV and IM. Pichard is IV and IM.
And IM, yes, sir.
Why they have practiced, that was the earliest method. Why
Yes,
they
sir.
have practiced that IV and IM? Which is not there in the later regimes. Zuspan and Sibais, they are all more only IV, not IM also. So in the olden days, the anasarca was so much, so they found it very difficult to maintain an IV line. So they thought they can give it intramuscular so that there will be a slow absorption. So they gave a heavy dose of 10 grams IM and 5 grams IM for thoroughly. Okay. So that was mainly for patients with severe edema. They practiced that. But nowadays we don't get that bad cases because of the good antenatal checkup and we are able to pick up cases earlier. So all the regimen has now changed to total intravenous instead of intramuscular. Okay, right. Right, go ahead. What other investigations you want to do?
Serum electrolytes. Then liver function test, sir. As per serum bilirubin, total proteins, serum albumin, alkaline phosphatase, aspartate aminotransferase, and alanine aminotransferase.
So will all patients with preeclampsia have any liver damage, or in a particular set of patients only you will have that?
So,
is it mandatory to do
severe preeclampsia, HELLP syndrome patients will have preeclampsia with HELLP syndrome patients will have elevated liver enzymes.
What is Sibal's criteria? Have you heard of Sibal's, SIBAL apostrophe S, Sibal's criteria? What are all the components in that? You have not heard about it, is it? Right. It is one of the method of assessing the severity of HELLP syndrome. Okay, HELLP Sibal's criteria, where the following things are taken into account: abnormal peripheral blood smear to show the immature cells, bilirubin more than 1 to 1.2 milligram per deciliter, LDH more than 600 international units, aspartate more than 70 international units, and platelet count less than 100,000. All these things go to form the Sibal's criteria. So based on that, you can make a diagnosis of the type of HELP syndrome in these patients. Okay. Okay, right. So after all these investigations, how do you anesthetize this patient? How do you assess the risk involved in this case?
So,
Hmm?
pregnancy, after routine investigations, everything, sir.
Hmm.
You check this. All pregnant mothers should be
Hmm.
full stomach. Start from first, sir.
Hmm.
After these investigations and routine pre-operative
Your case is
evaluation,
only elective. You said it's an elective cesarean section. So are you worried about full stomach?
sir, all pregnancy should be treated as a full stomach.
Very good. Correct. That is the answer expected out of you. Okay. So never just be relaxed because it is elective and she is adequately starved. Don't think or take it for granted that she will not vomit or have a aspiration. Okay. All pregnant women are supposed to be having a full stomach. Why? What is the reason?
Sir, because of the progesterone induced to decrease the gastric motility, sir.
Okay.
And normally gastric time itself reduced, and
Okay.
even 25 ml of gastric content of pH of 2.5 can cause aspiration pneumonitis.
Okay. Then
More chances of vomit,
vomiting or
vomiting,
regurgitation?
regurgitations,
What is the mechanism of that regurgitation?
or esophageal sphincter is relaxed.
Relaxed. So,
Progesterone induced lower esophageal sphincter relaxed.
okay. So what happens? Some pressure should be higher than the lower esophageal sphincter. Then only the pregnant
Intragastric,
can. Ah. So,
intragastric pressure is higher, sir. Higher than
So
the
what is that difference between the lower esophageal sphincter pressure and intragastric pressure is called normally? In a normal non-pregnant woman, which will be more, lower esophageal sphincter pressure or intragastric pressure?
lower esophageal sphincter pressure will be more, sir.
So this difference between the lower esophageal sphincter pressure and intragastric pressure is called
Last
barrier
class he told you.
pressure. Okay, so it is a barrier, barricade போடுற மாதிரி போலீஸ்காரன் அங்க போக கூடாது 1 ரூபாய் ரூட்னா barricade போடுற மாதிரி this lower esophagus is the barrier. So in pregnancy, because as you said, progesterone causes a relaxation, the intragastric pressure supersedes the lower esophageal sphincter pressure and is able to push the content into the esophagus. Okay. So the terminology usage is very important. Barrier pressure is broken. It is a very important term that you should use in the examination to make the avoid further questions, right? So delayed gastric emptying, increased volume, decrease in the barrier pressure or breakage of barrier pressure by relaxation of the lower esophagus and increase in intragastric pressure, and abolition of the angle between the lower esophagus and the fundus of the stomach. They become like a straight line. So normally that curvature also is lost. So all these factors make the passage of gastric contents into the esophagus much more easy and regurgitation happens because of this. Okay, all these points you should remember, right? So this being an elective case, what is your plan of anesthesia? Would you like to give regional or GA?
Regional anesthesia.
Regional. Why regional is preferred in this case, or for that matter in any pregnancy operative delivery we prefer regional? Why?
Regional anesthesia causes fall in the SVR, sir. So since it's a pre-eclamptic patient, afterload reduction will be there, sir. And then
Already there afterload reduction is there. Even during normal pregnancy itself, there is a reduction in SVR, isn't it? So if you cause further reduction in SVR, you are aggravating that problem.
yes, sir.
So is it good? Because of that you are doing that?
So multipharmacy avoided, sir.
Polypharmacy. Okay. You want to avoid
Polypharmacy avoided. Mother has been able to um, see the baby.
conscious
Early
mother.
release.
Bonding between the mother and the baby.
Mother and the child is. Risk of aspiration is avoided, sir. And then into laryngoscopy response might aggravate this preeclampsia, sir.
Failed intubation problem is avoided. Polypharmacy is avoided.
Difficult intubation will be there, sir. So
That's what I'm saying. Failed intubation or difficult intubation is avoided. Airway manipulation is avoided. Polypharmacy is avoided. Mother being conscious, she can have bonding and skin contact with the baby. Usually the physicians usually show the baby and also make the baby lie on the mother's chest for quite some time so that she is happy and the baby also has the feel of the mother's warmth, everything. Okay, so all these things, and technically also quite easy. You can just perform a spinal more easily compared to putting a tube and giving GA and all that, right?
And
Right.
better pain relief also.
Better post-op pain relief also there. So what are the disadvantages of regional technique, especially in this case?
sir, since she is already hypovolemic and volume contracted state, sir, administration of neuroaxial anesthesia will aggravate the supine hypotension syndrome, sir.
So how do you take care of that, or how do you prevent that?
Left by placing if the patient is in conscious, means we can the patient is not, if she is in what, we can make her to sit, make her in lie in left lateral position or a sitting position, sir. In theater, we can give a left lateral tilt up to 30 degrees, sir, or a wedge compression can be given.
So that is supposed to be done for every patient to avoid the iotocaval compression. That is not for correcting a preeclampsia. Question is, in a preeclamptic patient, we have agreed that there is a volume contraction. Adam has said 30% reduction is there in the circulating volume. So normally what is the advice given in a normal cesarean section with pregnancy, in a pregnant woman without any complication? Do you preload the patient or do you give fluids after you start the spinal?
Co-loading.
So we don't preload the patient here, we do co-loading. What is the safe limit of co-loading here? That is the reason why this question is being asked.
500 ml.
Blindly 500 ml, not based on body weight. Preeclampsia when you cannot give blindly 500 ml straight away, isn't it? So there should be some catch in that question. You must think before you answer that. So what is considered as a safe regimen or safe volume? You can give 1 to 2 ml per kg per hour. Okay, that is the safe limit. For example, if this lady is 65 kg, isn't it? What you said, 56. So 65 to 130 ml for the first hour. That is what you have to, and only crystalloid, right? Like ringalactate. Okay, and start that after you administer the spinal. Don't give it before you give the spinal. Okay. And another reason why you can escape or manage with this low volume is, what is the reason? Why they don't become, see, you are giving a very low volume compared to a non-pregnant, a non-eclamptic mother coming for cesarean where you liberally give fluids. You are not giving that much fluids. But still the patient will manage to have adequate volume. How? What will happen after the baby is delivered and placenta is removed?
Return of placental plate, return of placental blood back to the mother cell.
What is that called?
Auto transfusion.
Auto transfusion. Okay, so you have to give allowance for that also. That is the reason why you should not overload these patients. Okay, so you have to anticipate that 500 ml of blood will be automatically coming from the uterus back into the maternal circulation. So there are two reasons why you don't want to preload a preeclamptic mother is they can't hold more because of vasoconstriction. They cannot hold too much of fluid. Second thing is they will get an auto transfusion of 500 ml after delivery of the placenta also. Okay, so based on all these things, you are supposed to give a very titrated co-loading with just maximum of 1 to 2 ml per kg per hour as a fluid. Right. So what are the other complications of regional technique you know of? Not only in this preeclampsia, but any pregnant woman receiving spinal as an anesthesia for cesarean section. What are the problems that you normally face?
Shivering, sir.
Shivering, excellent. Postspinal shivering. What is the reason for the shivering?
Sir, sir, normally, change of the hypothalamic set points, anesthesia induced change of the interthreshold range will get changed. Anesthesia.
Will it happen even in conscious patient? It can happen in unconscious patient where a homeothermic individual will change into a poikilothermic individual. But when a patient is only half paralyzed or half desensitized and the above half is normal, will this resetting of the hypothalamic temperature center will happen?
So it usually occurs during the phase 3 because of the vasoconstriction of other extremities. It will try to compensate for the temperature loss.
So the answer for that is the difference between the surface temperature and core temperature. Okay, it is the core temperature which is sensed by the hypothalamus, not your surface temperature. Okay, whenever there is a difference of more than 1 degree centigrade between the surface and the core temperature, automatically all the mechanism to reset the body temperature to the original level or normal level will be tuned in. That is how you start working your muscles, which is the form of contraction, shivering, and increase the heat production so that the temperature will come back to normal. Okay, right. So that is one complication. Any other complication?
So postural puncture headache can be
On the table, as you are giving
hypotension, sir.
Hypotension. Very good. Then, supposing patient after you give the spinal and turn her to the operative position, she says, "I am not able to breathe. I am not able to speak." What does it indicate?
High level of
High level of high spread. Can it happen? What are the reasons for a high spread of spinal?
Sir, because of the lordotic changes in pregnancies, because of the growing baby, the lower level of spine gets more lordotic, sir, and engorged epidural plexus veins, sir. Because of the growing fetus, there will be a engorged epidural venous plexus, sir. So CSF volume will be reduced, so there will be a rapid ascent of CSF.
So how do you manage that, prevent high spread of spinal drug? What precaution you have to take?
Pillow under the shoulder, sir.
Okay.
Pillow under the shoulder can be placed.
Okay, that is one method. Then
little bit of head up position can be there, sir.
Very good. 2.
What about the volume of the drug that you're using?
Volume of the drug should be reduced, sir. We can give a lesser volume, sir.
What is the ideal normal recommended volume for a healthy cesarean section patient?
0.8 to 2 ml of 0.3%
bupivacaine. So will you make any alteration in that in a patient with preeclampsia?
Can reduce to 1.6 to 1.2.
Would you like to add any additives to that?
Sir, I'll add buprenorphine. I'll add fentanyl of 25 micrograms. Additives can be added with the low doses, additive can be added to prolong the duration of anesthesia.
So you can reduce the volume of local anesthetic by adding a
Additives.
additive in the form of a fentanyl. Okay. Right. So, right. Vasanthi, would you like to ask something?
I think he needs to say the hazards of general anesthesia, no, sir? And we can probably ask him more questions on labetalol, hypertensive crisis.
Yeah. So
What is the
hypertensive crisis, what is the method of or recommended guidelines for management of hypertensive crisis?
Hypertensive crisis, for immediate reduction in crisis, we can give IV labetalol of 10 to 20 mg every 20 minutes up to 160 mg per hour can be given. So next to labetalol, hydralazine can be given 2 to 5 mg IV slow over 5 minutes every 6 hourly can be given. If in spite of that the blood pressure doesn't come down, you can start on sodium nitroprusside, magnesium sulfate, and then nitroglycerin.
So can you reduce the BP from 170, 110 to 110, 80 within 1 hour's time? What should be the method of reduction of BP? What percentage you should reduce every hour?
Still, BP should not be reduced more than 20% from the baseline. Sir.
Baseline. Okay. From the starting line, not the baseline. From what you start every hour, you should try to reduce it by 20%. Why it is important?
Sir, cerebral auto regulation and all other systems will get affected. Sir.
It's reset at a higher level, so sudden reduction will cause a sudden ischemia of the brain, and they can go for complications. What is the common reason for death of a patient after GA in a preeclampsia?
So,
The most commonly recorded autopsy finding in a preeclamptic cerebral hemorrhage. Okay? So what are the other reasons for delayed emergence after a GA for a preeclamptic patient?
Patient might have been in the hypoxic ischemic encephalopathy. Sir. So there might be delayed recovery, and because of magnesium sulfate usage, there might be a delayed recovery. Sir.
Very good. Do you normally
instead of saying it, Rajesh, 1 minute. Instead of saying it like that, classify your answer. You say these are the possibilities, like the drugs that you have used in the preoperative period, the drugs that you have used in the intraoperative period, whether there has been any intraoperative problems, whether there has been hemorrhage, whether you have had any difficulty in intubation, whether there has been an hypoxia during that period, or whether there has been a hypertensive crisis during that period, or the patient has developed a pulmonary edema, and the postoperative. So if you take it that way, you will not miss any point. So then you will get all the points of a delayed recovery following general anesthesia for a patient with PIH. Okay, so now you say it that way. It will be much easier.
Preoperative, if the patient has been started on magnesium sulfate, madam, that might lead to post-op delayed recovery, madam. And then use of...
So will you stop the magnesium sulfate before you...
No, sir, it should be continued, sir. Should be continued intraoperatively and postoperatively, sir. Rather, we can reduce the dosage of relaxant and inhalational anesthetics.
So how do you manage the relaxant administration if the patient has received magnesium preoperatively?
Sir, about 2/3 of the dose of the your patient after intubation, suppose we are intubating with rapid sequence intubation, scoline has been given. Relaxant has to be given only after the patient has been recovered from relaxant, sir. And then we can use short-acting, medium-acting muscle relaxant like atracurium, cisatracurium there. We can use peripheral nerve stimulator to monitor for them.
That is the first answer you must say. You must always monitor the neuromuscular junction activity by using the neuromuscular junction monitor. Okay. And train of force should be monitored periodically, and top-up administration of relaxant should be done only when there is all the 4 responses are returned back. Okay, otherwise you should withhold and see that you use the minimum dosage of non-depressing muscle relaxant. That is the safer way than empirically giving 1/3 or 2/3 like that. Okay. So new usage of neuromuscular blocking monitor is very, very essential whenever a patient has received preoperative magnesium sulfate and you are going to give GA with control ventilation. Okay, right. So these are the points that you have to remember. What are the post-op complications? Can they still have eclampsia if there is if they have been treated for preeclampsia preoperatively?
Yes, sir. Can be up to 10 days of postpartum. There is a chances of eclampsia in severe preeclamptic patient is there.
Okay. Supposing the physician decides to allow monitor this BP and control it with on and off labetalol and allow the pregnancy to go on, and decides to allow for a normal vaginal delivery because first she has had a normal delivery. So she says, I will allow a normal delivery. What precautions you have to take?
So, planning for an early epidural analgesia.
So good labor analgesia is mandatory to prevent pain and contraction. What other monitoring you should do intraoperatively in this patient?
Monitor for observe for seizures or any headache or visual disturbances.
Maternal monitoring and fetal monitoring. Both has to be done. Okay. How do you monitor the fetus?
So, fetal heart rate monitoring can be done, sir. Fetal oximetry can be used, sir. Fetoscope, direct auscultation method can be used. Fetals are using fetal heart rate monitoring using CTG. And then fetal oximetry.
Nobody has. No, I've not even seen a fetoscope nowadays. I've only seen the CTG. It's always there, isn't it? See, fetoscope is becoming obsolete, but it is there. In some centers, it is still there, but usually CTG. Okay, you must say that first.
Right. Supposing you want to give a labor analgesia for this lady, how do you give a labor analgesia? What are the differences in the labor analgesia administered to a non-preeclamptic woman compared to a preeclamptic woman?
Preeclamptic in comparing with the normal pregnancy woman, preeclamptic woman will have a issue of edema around their airways, everything. So I'll keep a difficult airway cut, everything.
No. Epidural, you are going to give for labor analgesia. Question is, what is the difference between a labor analgesia administration in a pregnant woman coming with no complications compared to a pregnant woman with preeclampsia?
So these patients are they will have more edema, sir. So it will be difficult for them to administer epidural, sir. And then more chances of hypotension since their volume contracted. There is some more chances of hypotension.
Should you do some blood test? Should you keep doing some blood test and keep checking if something is going down over a period of time, whether they have done what counts?
Platelet.
First and foremost answer is that unless the platelet count is normal, labor analgesia should not be done in these patients. That is the answer that is expected out of you, to make sure that you are aware of the major problem of a spinal hematoma occurring. Okay. What is the risk of spinal hematoma? Even though it is a very rare complication, what is the most dreaded thing about the spinal hematoma? Has it got a good prognosis or poor prognosis?
Poor prognosis.
It has a very poor prognosis, and it should be removed or evacuated within 6 hours of identification.
Yes, sir.
Okay? So this is a very, very tough job. So that is the reason why you must always make sure that the patient does not have a bleeding tendency by checking the platelets. And if the platelets are normal and there are no clinical evidences of any bleeding and you plan to give a epidural, what is the second challenge in that? Normally, how do you check whether your epidural is properly placed or not?
Sir, loss of resistance techniques.
No, that is identification of the space.
Yes, sir.
After you identify the space,
In this patient, testos, adrenaline should be avoided, sir.
that is the second catch. Okay, testos is another challenge, whether to give a testos or not, especially if the BP is very high. Always you are scared to give a testos so that should not get into the blood and aggravate the blood pressure more. Okay, so these are the 2 points that are expected out of you. One is that I will check the platelet count. Second is I'll avoid doing a testos or use a lowest quantity of epinephrine available for checking the test or doing the testos. These are the 2 things that you want to add, right? Now, supposing after giving an epidural, you turn the patient, there is a maternal cardiac arrest. How do you revive the patient?
Call for help, sir.
Very
First,
good.
I'll observe the patient, sir. I'll check for the responsiveness of the patient, then call for help.
Just say the difference. Just say the difference in the CPR of
First
a
thing is
pregnant woman. Yeah.
circulation will be checked, sir. First, I'll maintain the circulation by giving a left lateral wedge compression, sir. Then airway breathing. Airway is usually secured with supraglottic airway devices. Airway will be secured, sir. Then after.
Nowadays, first preference is given to cardiac compression or airway?
Sir,
what is Coles?
Compression only.
Life support.
Life support, sir.
That is taught even for the basic public. Okay. So as a doctor, you should know first preference is only for cardiac compression, then only for airway. Why they have changed it? Earlier it was ABC, airway, breathing, circulation. Now it is a CAB, circulation, airway, breathing. Why they have changed it?
Most of the time, because the time taken to secure the airway, so that time circulation has not been maintained to brains.
So there is a more incidence of hypoxic insult to the brain. So that is the reason why you want to supply oxygen as quickly as possible to the central nervous system. So they have changed the whole concept from ABC to CAB. Okay, right. So the main 2 references here is the patient should have a tilt so that the weight of the uterus does not press on the IVC and the aorta, and compression should be started as a regular basic life support region. Okay, and then you must try to resuscitate the patient, or a firm board should be given underneath in the lateral position, and then only you should start the cardiac compressions. Okay, so that is what you have to remember. Suddenly they may ask you, because every candidate cannot be asked the same question, so you must be ready to think in all angles and answer quickly within the given time, right? Okay. So supposing she has thrown a fit after you have performed the epidural and you have turned, she throws a fit, what will you do? What are the reasons for a lady throwing a fit after you administer a first dose of your epidural for analgesia?
Because of the persistent preeclampsia, she might have thrown seizures, sir.
Persistent preeclampsia. So unfortunately, that may be the first time she throws a fit. That is one reason. Or what
What
other?
is last?
Sir, last, yes. Because of the local anesthesia system toxicity, she might have thrown seizures.
So you have done an aspiration, but you have given a volume, say 10 ml or everything as it. So how do you manage a patient who has thrown a fit? General management.
So first call for help.
Mm.
Secure the airway breathing circulation.
Mm.
Secure and after securing I will end.
Supposing already she is receiving magnesium and it is on flow. In that case, what will you do? If there is no magnesium flowing, what will you do?
First, I will give magnesium sulfate of 4 to 5 milligrams. 4 to 5 milligram
Milligram.
magnesium sulfate. So, 4 to 5 gram of magnesium sulfate.
That is the loading dose for starting. But in an emergency, will you give the same 4 to 5 grams when the fit is there?
2 grams IV.
2 grams IV bolus.
IV
Yes, 2 gram IV bolus within 5 minutes time you have to give. Okay. Supposing there is no IV line, there is no magnesium given preoperatively. So what will you do at the time? And the seizure is there.
Short-acting benzodiazepines can be given.
Like
Midazolam.
Or any other agent which can also be a cerebroprotective? Diazepam is not cerebroprotective. It's long acting. Any induction agent, anesthetic agent which
Thiopentone I will give, sir. 75 mg of thiopentone I will give immediately.
that is also a safe.
50 to 75 milligram of thiazole.
Can you introduce a oral airway at this stage, supposing while the patient is throwing a fit? Is it safe to open the mouth and put an airway in that?
Yes, sir.
Yes, sir.
No, the very fact that is asking a question like that, you must know.
Can introduce only a bite block, not an oral airway. Okay, no nasal or no oral airway should be introduced when the patient is actually fit, throwing a fit. Okay, so supposing after she has recovered, the physician wants to go ahead with a cesarean. Can you give a spinal at this stage? Patient is now fully conscious, oriented.
Yes, sir.
Is it safe to administer spinal now?
Sir, yes, sir.
Yes. Say boldly, you can give. So if there is no residual, you can give. There is no contraindication for giving this. Sorry, 1 second.
Yes, sir.
If this patient is not recovered, what is
Then
still want to do a cesarean.
Then I'll give a general anesthesia.
Please.
If the patient is not recovered and they want to quickly do a cesarean section, what is it called? It is allowed nowadays, isn't it? It is called perimortem cesarean section.
Emergency cesarean section.
No, it's called perimortem cesarean section. It is not emergency. Yes. Perimortem cesarean section and should be conducted within 5 minutes of cardiac arrest.
Recently, they
within
increased
5
1
minutes
minute.
of cardiac arrest. Exactly. Yeah.
Right. So, anything else, Vasanthi? Or shall I just show?
No, sir. I think we've covered everything, sir.
Yeah, I'll just show a PPT so that we can have some idea about.
Sir, I'll have to leave, sir.
Please, no problem. Go ahead.
You, sir. Thank you, sir.
Thank you, madam.
Thank you, madam. Thank you.
Is it visible? Kamachi?
Yes, sir. Visible,
Yes,
sir.
yes,
Full
Okay.
screen,
Okay.
it's on the PPT mode.
Yeah. So just make it full screen. So PAH and anesthesia, these are all the points I think you should all remember. Hypertensive disorders of pregnancy are one of the most common obstetric medical problems and are associated with a high maternal and fetal morbidity. Defined as new onset hypertension after 20 weeks of gestation, classified into preeclampsia and eclampsia, which are occurring after 20 weeks with proteinuria, And there is the other category called pregnancy-induced hypertension, which is also called as gestational hypertension, which also occurs after 20 weeks, but there is no proteinuria. That is the major difference. And chronic hypertension, which has been there even before pregnancy. So onset of hypertension even before 20 weeks or even before the patient becomes pregnant. So what are the other categories of hypertension that can happen before pregnancy? One is essential hypertension. Another is white coat hypertension. Third is called masked hypertension. Any idea what is masked hypertension? M-A-S-K-E-D, masked. It is something opposite to white coat hypertension. White coat hypertension is whenever the doctor or nurse takes the blood pressure. The blood pressure reading is high and otherwise at home readings it's all normal. Whereas masked hypertension is the clinic or hospital readings are normal, but patient has high BP readings at home. That is called masked hypertension, which can also happen before the pregnancy. And chronic hypertension, in which there is a superimposed preeclampsia. So hypertension will be there even before 20 weeks of pregnancy, but proteinuria will happen only after 20 weeks of pregnancy. In that case, it is called chronic hypertension superimposed with preeclampsia. The pathogenesis is always, you must remember, there are two stages. Two-stage process of pathogenesis. Abnormal placentation is the stage 1, and then endothelial dysfunction is the stage 2. So abnormal placentation with vascular remodeling, which can be due to maternal factors, genetic factors, or behavioral and environmental. Stage 2 is maternal syndrome of preeclampsia with endothelial dysfunction. The maternal syndrome of preeclampsia is characterized by decreased perfusion due to vasospasm and activation of coagulation. Now, this is the stage 1 where you see this picture is very important for all of you to remember. This is a normal pregnancy where the placental trophoblast, this dotted lines are the trophoblast. So they go and invade this is the spiral artery, which normally will be a artery like this. So all the muscular coat will be eaten away and it will become a dilated capacitance vessel. Whereas in preeclampsia, what happens, this invasion by the trophoblast is not adequate. So there is no dilatation of this spiral artery. So they still remain small caliber resistant vessels. So failure of proper trophoblast invasion leading to failure of conversion of small caliber. This is a small caliber spiral artery, which is a resistant vessel, to large caliber capacitance vessel. So in normal pregnancy, this is what will happen. And in the second process of stage 2 endothelial dysfunction, you can see these are all the changes that happen. So there are two imbalances. One is the vasoconstrictor versus vasodilator imbalance, more of vasoconstriction resulting in vasospasm, and between the anti and pro-angiogenic factors are there. So there are two things that are happening in these cases which result in vascular smooth muscle contraction as well as permeability increasing. So the net effect is vasospasm, capillary leak, and activation of coagulation. So the same thing, and the duration. This first stage is called preclinical, which because all these things, inadequate invasion and improper implantation, all these things take about 20 weeks. After that only clinically patient starts getting hypertension, proteinuria and all those things. So these two stages are the preclinical stage, that is before 20 weeks, and clinical stage after 20 weeks, which exhibit as a clinical features of inflammation, hypertension, proteinuria, edema, all these things happen. And the grades of blood pressure are classified into mild and moderate and severe. But preeclampsia nowadays, as earlier we said, it is divided into with severe symptoms, without severe symptoms. That is how it is classified. And the earlier classification of mild, moderate and severe are all now given up. Then headache, visual disturbance, upper abdominal pain, nausea, vomiting, and brisk deep reflexes, all these things happen. In hematology, there is a thrombocytopenia, altered coagulation, HELP syndrome features. In the biochemistry, there may be kidney involvement with altered urea, creatinine, sodium, potassium, and serum uric acid levels also increase. When proteinuria is there, elevated urine, protein and creatinine, low albumin, low glucose in severe cases, elevated enzymes, bilirubin, all these things go ahead. And the main investigations we do are full blood count, urea electrolytes, liver function test, urine test, and all these things. The airway evaluation, gastric volume measurement, and vascular assessment, and lung fluid assessment are all done with the help of ultrasonogram, optic nerve sheath diameter measurement, and neuraxial blockade. All these things we use nowadays, the ultrasonography. And there is something called ROSE scan, rapid obstetric screening echocardiography, which is done using the transthoracic echocardiography measurement to assess the fluid status as well as the cardiac function in the preeclamptic patient. And factors associated with development of preeclampsia, they can be pregnancy associated. It usually happens in first pregnancy as well as multiple pregnancies, donor insemination, molar pregnancy, chromosomal abnormalities. And if the mother is more than 35 or less than 25, family history of preeclampsia, and booking diastolic pressure of more than 80, associated diabetes, obesity, chronic hypertension, renal disease, antiphospholipid antibodies, factor V laden, SLE, some autoimmune diseases, and paternal fathers, first time father, all these things have been attributed to the development of preeclampsia. The important life-threatening complications are hypertensive crisis, pulmonary edema, and eclampsia. And Sibyl's criteria, as I said earlier, these are the things which are used for assessing the HELP syndrome, abnormal peripheral smear, bilirubin more than 1.2, LDH 600 and more, AST more than 70, platelet count. And maternal complications, cardiovascular system, generalized vasoconstriction, decreased circulating volume, left ventricular failure, nervous system, headache, visual abnormalities, vomiting, confusion, hyperreflexia, altered cerebral perfusion. Cerebral hemorrhage is the most important dangerous complication, and convulsions because of irritability. The respiratory system, there could be generalized edema with enhanced upper airway edema. Non-cardiac pulmonary edema due to capillary leak is also very common. And complications in the mother, they can be renal complications and renal failure because of various reasons. And in the liver, it can be abnormal liver function tests, subcapsular hemorrhage in HELP syndrome, and in hematology, altered coagulation, increased fibrinogen usage, thrombocytopenia, and impaired platelet function. DIC also can sometimes happen. And because of HELP syndrome, bleeding again can happen. And complications in the fetus are decreased placental perfusion, placental ischemia and infarction. Patient may be smaller in growth for the age, and sudden placental abruption also can happen, and preterm labor is very, very common. What are the controversial areas in management? If preeclampsia develops at an early stage gestation, when and how delivery should be occurring? That is one question that you have to think about. When is invasive monitoring needed? Normally, we avoid central line or pulmonary capillary measurements because of the bleeding problem. But in very severe congestive failure patients, we have to go in for this. But generally, we try to avoid all this invasive monitoring. What are the benefits and risks of various antihypertensives? How should we manage an eclamptic seizure? Why magnesium is preferred over other anti-seizure medications? And how should we manage fluids? Platelet count, what is the safe value for neuraxial block? Is spinal safe in severe preeclampsia? Should phenylephrine replace ephedrine to treat hypotension? So these are all the questions that are usually pose a challenge to you. The management strategies, only cure for preeclampsia is delivery of the baby and the fetus and the placenta. Maternal safety versus fetal prematurity is the major criteria. If at any stage, if there is a risk to mother life, immediate delivery should be performed. But if you can allow the baby to attain maturity, then if there is no threat to mother's life, we can easily allow the maturity of the baby. So gestational hypertension, mild preeclampsia can be managed at home with frequent maternal monitoring and fetal surveillance. Severe preeclampsia cases need admission. Favorable cervix, that is, which is adequate for fetal maturity, after 36 weeks, they can undergo induction with proper pain relief and allow normal vaginal delivery. Whereas if there is an unfavorable cervix which is not dilating adequately, should be subjected to elective cesarean section. Less than 34 weeks with severe preeclampsia, delay delivery for 48 hours to administer steroids for lung maturity. So that is, if you can wait without converting the preeclamptic mother to eclampsia, by 48 hours, that is at least 2 days time to administer steroids. Magnesium sulfate infusion with antihypertensive treatment will help to control the BP. HELP syndrome should be treated with large doses of dexamethasone 10 mg BD. And the most important dilemma in treating hypertensive crisis, maternal complication versus fetal safety compromise. High maternal BP can result in pulmonary edema or cerebral hemorrhage. So high systolic BP causes cerebral bleed and stroke. Invasive monitoring rarely needed since most are young patients with fewer chronic illnesses, but arterial line will be useful in patients. Consistent BP more than 160, 110, who are on IV vasodilators, who have coagulopathy and need frequent samples, those who are obese and are severely edematous, and if pulmonary edema and frequent ABG is needed in all these patients, an arterial line will be useful. CVP or PA catheter are not normally used because of risk of bleeding, need for trained nurses to manage, but they are indicated in cardiac failure, pulmonary edema with a large EIA gradient, oliguria despite fluid resuscitation. All these cases we have to go for invasive monitoring. Drugs used in the treatment of hypertension, methyl dopa, usually 250 mg 3 times a day, acts as a false neurotransmitter, but nowadays most physicians don't prefer to use this because of all the side effects. Labetalol is the first drug of choice, 200 to 1600 mg in divided doses. And mode of action, it's a combined specific alpha and non-specific beta adrenoreceptor antagonist. The ratio of alpha blocking effect to beta is 1:3 for oral and 1:7 for IV. And another important thing, it does not cross the placental barrier and has no effect on the fetus. But the side effects are bradycardia, bronchospasm, so contraindicated in asthmatic also, just like because it's a non-selective beta blocker, you have to be careful in cardiac asthma patients and pheochromocytoma patients. Nifedipine, route of administration oral, and calcium channel antagonist. Side effects are headache, dizziness, tachycardia. Hydralazine is mainly IV bolus. It's more of an emergency drug, not as a routine oral dose. And the side effects are fluid retention, palpitation, headache, contraindicated and severe tachycardia. Trazodone is an alpha blocker, which is also sometimes used when they don't respond to other. Beta blockers are very rarely administered, and AC inhibitors and the ARBs should not be used because they are teratogenic and they cause fetal problems. Diuretics are very rarely used. Magnesium sulfate, both as an anticonvulsant as well as for control of blood pressure, it can be used. You must read about all the various indications and their usage. Prevention and control of seizure is by IV magnesium sulfate, 4 mg bolus, 10 minutes, followed by 1 to 2 grams per hour until 24 hours post-delivery. The maintenance dose is stopped or decreased when the patient is oliguric. or if the serum magnesium levels are higher than therapeutic range. In the event of recurrent seizures, a further bolus dose of 2 to 4 gram IV can be given if it is already flowing. If further seizures occur despite the above, inform the intensive care unit as additional seizure treatment may be required, including airway support and ventilation. 44% of epileptic fits occur after delivery, so postnatal vigilance is also very, very important. Administer high flow oxygen, turn patient to full left lateral decubitus position, introduce a bite block, suction and clear secretions. Small doses of thio or propofol can be given. Additional 2 milligram of magnesium can be given, and CT MRI if there is a recurrence of seizure, and consider delivery induced by either normally or by LSCS. So fluid management, 2 changes in preeclampsia. There is a contracted vasculature tree causing contracted blood volume and sudden vasodilatation if vasodilator like hydrazine is administered, and leaky capillaries causing pulmonary edema compounded by reduced plasma albumin due to dilution or proteinuria. So safer to err on the side of less fluid intake. Maintenance fluid intake, including all infusions, should not exceed 1 ml per kg per hour. Urine output of 0.5 ml per kg per hour is an accepted minimum. Co-loading is preferred to preloading. That is, these things you have to remember. Time and mode of delivery is dependent on the severity of the condition and the gestation of the fetus. The decision to deliver depends largely on maternal rather than fetal well-being. So maternal life is more important than fetal well-being. So the decision should always go in favor of the mother rather than the fetus. And anesthetic consideration, choice of anesthetic technique for cesarean delivery depends to a large extent on individual circumstances, though a regional technique is preferable in most of the times. Hemodynamic stability following spinal anesthetic was comparable to epidural blockade. So subarachnoid anesthesia in women without an epidural in situ, spinal or combined epidural is preferred. Epidural anesthesia advantages: helps to control BP, improves placental blood flow, abolishes labor pain, can be extended to provide operative anesthesia. Disadvantages: not suitable in patients with low platelets, more chances for hematoma formation. Coming to general anesthesia, indications: whenever there is a contraindication to regional blockade like low platelets or coagulopathy, post-ictal patient with abtendant, that is once they have not fully conscious after a seizure, then that patient is better to go for GA rather than regional. Presence of pulmonary edema associated with hypoxia, patient refusal for regional technique, and pressure response to laryngoscopy can lead to dangerously high surge in blood pressure that may lead to intracranial hemorrhage. That is a very important thing in GA. So measures to attenuate the response can be in the form of magnesium, labetalol, and potent parenteral opioids like alfentanil can be given. And delivery management, antacid and antiemetic pre-medication should be administered. Antihypertensive, anticonvulsant drugs should be continued. Intubation may be difficult due to edema. Decreased pulmonary compliance may impair ventilation. The woman has received magnesium, muscle relaxation must be carefully monitored. Routine use of ergometrin and symptometrin is avoided because they can produce very severe hypertension. And non-steroidal anti-inflammatory drugs should be withheld if the patient has any renal problem or platelet function. And paracetamol may need to be withheld if there is a laboratory evidence of significant liver. So HELP syndrome patients don't give paracetamol as we routinely give in all these days. Now, what are the allied topics you should learn for exam purpose? Physiological changes during pregnancy. So instead of asking for preeclampsia, they can ask all the changes during normal pregnancy. Anemia complicating pregnancy can be asked. Anesthetic management of elective and emergency cesarean section. Management of antepartum and postpartum hemorrhage. Labor analgesia, neonatal resuscitation, uteroplacental circulation. So all these questions can be asked. So these are the things that you have to remember with that. Any questions or any doubts? Somebody I saw typing nowadays they recommend 300 milligram of aspirin. Yes, that has been there for a long time, but there have been contradictory reports whether it is really useful in controlling the preeclampsia or the coagulation activity. But again, there is a revival of that idea. So nowadays they are again, initially they tried that and did a lot of studies and found that it's not been very useful. But now again there is a rethinking on that concept and people are now using prophylactic aspirin administration in patients diagnosed with preeclampsia. Okay? But if there is a liver involvement with the HELLP syndrome, then the aspirin treatment should be withheld. It should not be given. Okay? Kamachi?
Yes, sir. Any other question from the students? Students can unmute yourself and ask questions.
I think everything is clear.
Sir, I personally have one doubt, sir.
Yeah.
Actually, the recent guidelines are quoting about angiotensin receptor antibodies as a pathophysiology for what is the role of this particular autoantibodies against angiotensin 1 receptors? Will there be any role for steroids during the later stages of pregnancy, sir?
Steroids is there recommended only in HELP as far as I went through all the available material. But in cases of preeclampsia, steroids as it is, except for the lung maturity of the baby when you want to deliver that, the maternal indications, I don't think there is any indication for steroids.
Yes, sir. But there are a lot of literature quotes about the angiotensin 1 receptor autoantibodies as a one pathophysiological mechanism for PH.
Okay. Is it given in an article? Because none of the textbooks have come out with that. This is the newer version of the ICA book where the current concepts in page number 34, there is an article which says what? The pregnancy-induced hypertension and update. See, this is the chapter that is being there. And here they are not mentioning anything about what you have mentioned. So
yes, it is given in the latest textbook of Barash textbook.
Barash, okay.
Yes, Indian edition.
Mm.
I can quote the reference personally to you, sir.
Okay.
I quoted a reference also.
Yeah, but here still they are talking only about abnormal placentation and the imbalance between the thromboxane and prostaglandin nitric oxide and endothelin. Endothelin derived relaxant factor, but I don't find any mention about the angiotensin 1 antibodies or anything here.
Yes, sir. Yes, sir.
So I am not aware of that. Maybe
the two factors, all the three factors are mentioned in the latest textbook, sir. One is thromboxane versus prostacyclin. There is 7 times more vasoconstrictor than the vasodilator. That is one pathophysiology. And second is vascular endothelial growth factor.
Yeah, that is their endothelium derived
anti-angiogenic factor.
Yeah.
That you mentioned in a slide, sir.
That's what that picture shows all these things there. But I will again go through that diagram that is given there to see whether there is any mention about angiotensin 1 or not.
Yes, sir. You have quoted in that slide, sir, that FMS like tyrosine kinase 1.
Yeah.
The angiogenic factor.
Yeah. And
after that, they have quoted this angiotensin receptor antibody, autoantibodies.
Okay.
And compared to the normal cesarean sections after spinal, this PH patients, their BP is holding better because their vasoconstriction state is so high already.
Yes. Previously, it was thought that they will crash BP and there will be a lot of problem, but that has not happened over a period of years. So when we were postgraduates, if we say spinal for a preeclampsia, we definite to fail. because we are supposed to say only GA. But now if you say GA, you are going to fail. You can say spinal safely.
Spinal is all the time preferred than
All
any
the-
other form of GA,
yes,
sir.
yes.
Yes, sir.
Yeah,
And
right.
even the empty stomach, emptying of stomach, gastric emptying status. For that also, they are quoting some latest guidelines of ACOG and ASA, stating that up to 2 hours of clear fluids can be given in
Okay.
normal labor, uncomplicated labor.
Mm.
They have reduced the
Yeah,
fasting
yeah.
guidelines for that.
Fasting
But at any cost,
guidelines, yes.
solid foods should not be used.
Yeah, that is
Please read
a
in the
recent thing
latest
for
textbook
all
of
the fasting guidelines. Generally has been found to give clear fluids up to 2 hours after the ERAS and the pediatric changes in guidelines, because they found that it helps in increased motility of the gut and makes the stomach contents go down.
Yes,
And
sir.
also gives a sense of well-being for the patient that they are not starving. Okay.
Yes, sir. Yes,
So
sir.
psychological advantage is
Yes, sir.
also there.
Yes, sir. So a lot of new things have been added in the latest textbook of Barasha,
Okay.
particularly the Indian version.
Okay.
So I think students should go back and refer the latest textbook, sir.
Okay.
Yes, sir. Next week, can we have a discussion on hemorrhage complicating pregnancy, sir? So that in a row we can complete all the obstetric cases.
What
Obstetric
complicating?
obstetric
Hemorrhage.
hemorrhage. Yes, sir.
Hemorrhage. Okay. Yeah, we can have that. Okay.
Okay, sir.
Right.
There is, actually, it's time for the students to ask more questions because you will be facing the exams in a couple of months as soon as possible. So better you ask for all the exam related questions to professor so that you can be well prepared for the exams. I invite the students to ask more questions about this very common and popular topic for exams.
That further they should go through and prepare their questions and keep it ready and come. Then only they can. So they think only the person who is presenting should prepare. Everybody should read and everybody should have a list of questions so that you can develop the habit of asking questions. Okay. So that is how you improve your knowledge. Get
So with no questions, shall we wind up?
Yeah, we'll wind up. Okay.
Okay, sir. Thank you, Professor, and thank you, dear students. We'll again meet again next week with a very interesting topic on obstetric hemorrhages.
Okay.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.